Start.
Hi, everybody. It's so good to see you. It's so good to be back. This is webinar number number 9. Gosh, I'm losing track here. It's welcome to the world. Welcome to all 5 continents. It's so good that you guys are here. I hope that at the moment the weather is good, the situation is good wherever you are. This is webinar number 9. Welcome to your world, together, apart. We've got a fantastic lineup for you today. And before we start, I just want to do some housekeeping. Remember that for the strabismus webinars, if you did those, or even if you just saw one, remember they are on our YouTube channel. Please go and see them. If you do, please take this survey. We're trying to make things better for you. We want to make sure that you are getting the type of educational experience that you want. The survey will be open until 5 p.m., 30th of June. That's Eastern Standard Time, USA, Eastern Summer Time, I should say. So I hope you'll participate in that. Thank you for being with us. We've got everybody here today. We've got a fantastic panel. I want to start off by introducing some of our panel. Let me start off by mentioning Darius Hildebrand. I've known Darius for many, many years. Darius was supposed to be here. Darius did his ophthalmology residency at Moorfields. He's the president of the European Pediatric Ophthalmological Society. He's the head of the Pediatric Ophthalmic Service in Oxford. We're thinking of Darius at the moment because his wife is unwell, and our thoughts, our prayers, our best wishes, our highest hopes for Darius and his wife at this time. Darius, sorry you can't be here, but we are thinking of you and your family. Jagat Ram, well, I don't know quite what to say about Dr. Jagat Ram. He is the director of the Postgraduate Institute of Medical Education and Research in Chandigarh, professor of ophthalmology there. He is on the board of governors of the Medical Council of India. As a researcher, his contributions to ophthalmology, in particular pediatric cataract, have been outstanding, absolutely outstanding. And he's published in the New England Journal of Medicine, the Lancet, and he was awarded the highest civic medal in India in 2019, which is the Padma Shri, by the Honorary President of India. Dr. Jagat Ram, I can't tell you how thrilled we are to have you here today. It's an absolute honor, and I look forward to hearing what you have to say. The next man really doesn't need any introduction. Ramesh Kekunnaya, friend for many, many years. You see here at the bottom right, Ramesh and myself and all the WSPOS Scientific Bureau and family. Not all of them are there. Ramesh is head of the Just TV Ramanama Children's Eye Care Center at L.B. Prasad Eye Institute in Hyderabad. Has an amazing special interest in complex strabismus, pediatric cataract, and pediatric neuro-ophthalmology. Ramesh, as always, these webinars wouldn't really happen without your hard work and dedication, and also the support of Akila, your wonderful wife, who I have to say is not only the better half, but the best half of you. So on that note, Ramesh, take it, it's all yours.
Thank you, Ken. Thank you so much for that. Again, welcome everyone for this 9th webinar on the consecutive week we are having. And we are having one more pediatric cataract webinar today. I just want to give some more information for the audience today. As you all know, there are 3 streams happening: Blueberry, Facebook, as well as YouTube. Type in your questions wherever you are watching from. Panelists will try to answer them as much as possible during this webinar. If for some reason if we can't answer, we will send it as a PDF copy later. So type in your questions, whatever you have with regards to today's talks. One of the other thing I want to mention here is we always learn and share. For that, this menti.com, you can type in www.menti.com in your browser or computer or mobile phone. The passcode for today, I think this is very, very important. Please note it down. 423495 is the passcode. So you can open by typing menti.com. Everybody, including panelists, everybody can do that, so that we need to know what is your preference, what's the preference across the world. So it really helps us to understand what is changing and what's the most preferred technique. So enter your passcode 423495. If you want a quick response code, you can also scan this. This is on the screen now. You can just QR code this, and then you can directly go to the link. So I just encourage every one of you are watching whichever stream, just participate in this. It's amazing. We get a lot of information from this. Coming to the panelist, as Ken said, he's been a friend for more than a decade now. He was born in Nairobi and then grew up in England. He worked for many years in Great Ormond Street for sick children in London. After that, he moved to USA. He is currently a professor of ophthalmology, division chief of pediatric ophthalmology and strabismus at UPMC Children's Hospital, Pittsburgh. He is also a medical director, digital health, UPMC Children, and he is vice chair for the quality at UPMC. So you can see his fantastic family. It's been very wonderful to know him for all these years. Thank you, Ken. The next panel, what we have is Dr. M. Edward Wilson. He's a professor of ophthalmology and pediatrics, and also N. Edgar Miles Endowed Chair in the Storm Eye Institute, Medical University of South Carolina, USA. As you all know, in the pediatric cataract field and also in pediatric ophthalmology, there are significant number of papers which he has contributed. He is an astute clinician and a surgeon par excellence. Many of you have read his textbook also. He has contributed immensely to pediatric cataract. We are really honored to have him today to talk to us. The next panelist is Dr. Yee Fong Choong. He is the medical director and head of pediatric ophthalmology and strabismus services at International Specialist Eye Care Center, Kuala Lumpur, Malaysia. He did his pediatric ophthalmology fellowship from Great Ormond Street's Hospital for Children and also King's College University Hospital, London. He has a significant special interest in pediatric cataract, pediatric glaucoma, and myopia progression. Many of you know him. He takes some wonderful photography. He loves photography and he loves travel. Some of you who didn't have seen it, I really encourage all of you to see. And he's a wonderful person. It's great to have you today for this webinar, Yee Fong. Before I hand over this screen to Yee Fong for his first talk on management of Capsule, there are 3 Menti questions already will be there on the screen. Number 1, 2, 3. It'll come one by one with the gap of 30 seconds. And we will keep repeating it, because if you missed a chance, just refresh your browser. You can go back and answer. It's a pleasure to invite Yee Fong Choong to speak about capsular management. Yee Fong, all yours.
Yee Fong, before you start, I'm getting shout outs from all over the world. We have people listening from Saudi Arabia, Indonesia, Brazil, Sweden, Nigeria, South Africa. We've got Venezuela. We've got Argentina. We've got, oh my goodness, we've got the UK. We've got 7 states from the USA. It's a live international global audience. All yours. No pressure.
Thank you very much, Ramesh and Ken. It's delighted to be invited to speak in this webinar. I'll be talking about managing the capsule in pediatric cataract. As we know, there are many ways of managing the capsule. There's the manual method, which is the commonest, and this is the focus of my talk today. But the capsulotomy can also be performed using the vitreous cutter or the femtosecond laser. For the femtosecond laser, the main disadvantage, of course, is the cost of it. And also, it cannot be performed in all eyes. One can also use the Zepto precision pulse capsulotomy. And I think Ramesh have got significant experience in this that he can share later. Then we also can use the diathermy capsulaxis or the Fugo plasma blade. But as I mentioned earlier, the focus of my talk will be on the manual method, which I think is most accessible and in some ways give very good results. Now, the manual capsulotomy can be performed on both the anterior and posterior capsule, which is important because some of the other methods mentioned earlier can't do that. It often results in strong, smooth capsular edge that is more resistant to radial tear, unlike perhaps, for example, the femtosecond laser, which may cause a high incidence of radial tear. The other advantage I find that can be performed through small corneal incision. Therefore, you can use small gauge instruments like the 23 or 21 gauge instrument for capsulaxis. This is important because you want to maintain the anterior chamber stability during your manipulation, particularly during the cataract extraction. You don't want to have too much movement of the iris. It can be performed in all eyes of all sizes. Because it's a manual method, it is less inflammatory, unlike other method that uses exogenous energy. It can be quick. It is low cost without any additional expensive instruments. But the disadvantage of it is the cost and also the steep learning curve. Now, this is the first video that I'm showing you doing this procedure using trypan blue assisted capsulaxis. I often infuse the trypan blue with a gas bubble for better staining. After 1 to 2 seconds of staining, I will wash it out with balanced salt solution. After stabilizing the anterior chamber with viscoelastic, I then go ahead and make 2-step incision to the diameter of the intended size of the capsulaxis. This is a modified version of the 2-incision push-pull technique by Nischal. I would then pick up the torn edge in the proximal end and then start advancing the tear. Now, as opposed to adult capsulaxis, whereby most of the forces are tangential to the tear, in pediatric cataract, as you know, because the capsule is more elastic, whenever the tear threatens to run a bit too far out, you need to redirect the forces towards the center again. And you also need to regrasp the edge of tear repeatedly to ensure better control. As you can see here, one can tear this capsulaxis in this fashion in a safe way. And whenever you try to, when the rexis threaten to run out, you just need to ease it back to the center. You can do it in a very smooth, repeated fashion until you complete the rexis. I will next show you another video, which is another anterior capsulaxis that is performed but without trypan blue staining. In a similar fashion again, I would then make 2 incisions, one proximal here, and then one distally to the diameter of the intended capsule. I often do the second incision, although I sometimes do not use it, partly because if I do run out or I do feel that I'm losing control from the initial capsulaxis tear, I can actually have a second starting point to rescue a potentially running out situation. So this is like an insurance, if you like. So you can see that again, the tear is done by moving it slightly tangentially, but with some forces directed to the center as well. And typically, this will then result in a good capsulaxis with good integrity of the capsular torn edge. Now, I will next show you a video of the posterior capsulotomy. Now, in this situation, I find that the 2-incision push-pull technique are very useful. So again, I make 2 incisions to the diameter of the intended size of the capsulotomy. And then I pick up the distal edge. And then in this situation, most of the forces is directly centrally. By just lifting it slightly and then just pushing away, you can see that the edge will tear out in a fairly circular fashion away. And once you reach about equator or slightly past it, then you can start distally by engaging it and then pulling it towards yourself. And then you can complete the tear by grasping it and just move it to 3 to 9 o'clock. And by just doing these simple movements, you can very easily complete the posterior capsulotomy. And following this, you can perform the anterior vitrectomy and prepare the capsular bag for implantation. Now, this is another case whereby we encounter quite commonly in children, whereby there is a posterior plaque at the posterior capsule. It's very important that we remove this plaque carefully, because this plaque can sometimes be very adherent to the posterior capsule, and if you don't do it with care, you can result in radial extension. After making the 2 incisions, again to the desired size of the rexis, you just pick the distal, the proximal end, and slowly tease out. You can see that I'm making these teasing movements so that we carefully dissect and tease away the posterior capsule. Now, some of the posterior capsule is adherent to the plaque, and it's very important that you want to make sure that you disengage them all and make a smooth tearing movement all towards the center. The key is actually picking it up and then just drag it towards the center, and that typically can result in a smooth edge. And once all the different strands are disengaged and removed, ensuring that everything is now mobile, is no longer anchored to the posterior capsule, then one can just remove the plaque. There's still one strand at about 8 o'clock, which I'm going to just remove now. Just pick it there, and then just pull it towards the center, and then that's it. And then you just remove the plaque. Now, following the posterior capsulotomy, one need to prepare the capsular bag for implantation. Now, during this time, it's very important to separate the 2 part of the capsule, the anterior and the posterior capsule, away from each other, so that the bag is fully distended. And you want to see the edges of the anterior capsule and the posterior capsule clearly, so that when you implant the lens, you can ensure that it goes into the bag. It's very crucial to implant, if you do implant intraocular lens in the eye in very young children, you want to implant the bag. You can see that as you inject the viscoelastic will actually delineate the posterior capsule very well. And you can see that some of the viscoelastic also goes into anterior vitreous phase. And once you can see clearly the anterior and posterior capsule, then you can then proceed with implantation. That's it. That's the end of my talk. Thank you.
Thank you very much. That's fantastic. So what we're going to do is I'm going to show a couple of slides basically talking about posterior optic capture. But I haven't got a video. Hopefully we'll have time and we can get Dr. Wilson to show us that. So this is a child with aniridia who I did a cataract operation on. And what I would like you to see is that on an OCT, you can see how curved the posterior capsule is here. But have a look here. In one eye, I put the lens in the bag. So you can see the whole of the optic, and you can see the haptics are in the bag. Here, I hope you can see the anterior capsule, and then you see the posterior capsule. When you do a posterior optic capture, you get this very nice kind of like diamond or oval shape. Because what I've done is I've popped the optic underneath the posterior capsule here and underneath the posterior capsule here. Now, the beauty of this is that you can see what happens further down the line. So in the eye that had the, in the bag, you've got a nice opening, but look at the lens epithelial cells that are growing right up to that opening. In the eye that I did the optic capture, you can see that where the anterior and posterior capsules were opposed, the lens epithelial cells stopped growing. You've got a very much cleaner looking visual axis. And I know that Darius is feeling, together with Vladimir Pfeiffer, who do this a lot, is that the optic capture of the posterior capsule gives you a much better visual axis clearance, and that their rates of visual axis opacification are much lower in the younger children. So that's something worth looking at. So if you look at this very clearly, here we are where the anterior and posterior capsule fuse, if you like. The lens epithelial cells just cannot grow any further. They can't migrate. So you get a really nice, clear visual axis. So I'm just going to stop there for a second. There's another slide that I do want to show, but I want to ask the whole panel, how many of you do posterior optic capture and under what circumstances? Jagat Ram, let's start with you.
Yeah, we do posterior rexis when we fail to implant the IOL in the capsular bag. Capsular bag implantation, our first aim. If sometime posterior capsulotomy is larger and there is a problem of implantation of IOL in the bag, then our second choice is capture of the optic capture. That is the second choice.
Okay, Ramesh?
Yeah, I generally don't do optic capture unless if it is in a sulcus or some of the traumatic cases. I think we need to do it, otherwise the lens floats there. So I would say generally I would not do optic capture, but certain situations like traumatic cataract and some of the patients where we are implanting in the sulcus, I try to do that. Okay. And having said that, my posterior capsular rexis size is generally larger than what many people do. I really do a bigger one.
Ed?
I think special situations, trauma where your anterior capsule's been torn, you want to keep the lens centered. Posterior optic capture is a good way to center a lens and keep it from migrating. Sometimes in a 3, 4, 5, 6-year-old where I might ordinarily do a vitrectomy, if I've decided that I want to do posterior capsulorhexis and no vitrectomy, in those situations, optic capture, I think, helps if you don't have the instrumentation or you don't want to do a vitrectomy. I do a vitrectomy more often. I think it's safe. But for those that don't want to do it, you can extend the age lower with posterior optic capture of the absence of the need for the vitrectomy.
Yee Fong?
I don't generally do optic capture, but again, like Ramesh, I make fairly large posterior capsulorhexis, and I do fairly extensive anterior vitrectomy, including the area posterior to the posterior capsule, not just in the center, but also peripherally. By doing so, in my cases, I don't encounter that many cases of reduced axis opacity.
Okay, so, but when you look at the pictures that I've just shown, I mean, it makes a powerful argument that actually optic capture should be perhaps a standard technique, because the two eyes of the same patient, clearly one has much less lens epithelial cells than the other in terms of migration. So, I mean, I don't do it regularly. I'm like the rest of you, but I tend to do it. So whenever the anterior capsule's affected, I think it's a good thing to know about when you have an aniridic eye, because in aniridic eyes, you can't place the lens in the sulcus, right? I mean, you've got to get it in the bag. And if the anterior capsule's not great, you've got to learn about optic capture. Let's change the subject a little bit. You mentioned anterior vitrectomy. If you, Ramesh, we'll start with you. If you were talking to a brand new attending or consultant, and you had to give him one piece of advice about how to do anterior vitrectomy in pediatric cataract surgery, what would that advice be? I'm going to turn to all of you to ask you, what is that advice?
Yeah, I would say do it after primary posterior capsulotomy. Don't do a PPC with the vitrector. Once you have done it, I would try to do a subcapsular anterior vitrectomy, not to go very deep. And also, what is the end point? The flapping of the posterior capsule should stop, and there should not be any peaking. Till then, you need to continue. Okay. I think this is what one point I would say.
That's great. Yeah, I just want 1 point. I want 1 point from everybody. So Ed will come to you.
Yeah.
Ed?
I think that using the bimanual approach, I think you need irrigation separate from the vitrector and high-speed vitrector. So the vitrectomy doesn't cause retinal detachment. Traction causes retinal detachment. So we have to cut down on vitreoretinal traction. And the best way to do that is a modern high-speed cutter.
I think that's a really, that's a superb point. It's not vitrectomy, it's the traction that causes. When you say high speed, are you saying 500, 1,000? Because there are going to be many people in the world listening to this. And by the way, I'm getting told off by Spain, Germany, Philippines, Chile, Egypt for not mentioning them. Many people in the world may not have access to the really high-speed vitrectors. So what do you think is high speed in terms of minimum speed of cut rate?
I mean, I use 7,500 cuts a minute, but I think the machines that are at 800 or above per minute are probably safe. I don't think they're as safe as the really high. You know, we have machines now that are 10,000 cuts a minute, but my routine is 25 gauge, 7,500 cuts a minute.
Okay. Jagat Ram, what is your advice to the new consultant?
Yeah, actually, we do primary posterior capsulotomy and then limited anterior vitrectomy, and then cut rate is not so high as mentioned by Dr. Amy Wilson. Cut rate we try to keep low, but once I think capsulotomy is complete, because sometime more cut rate it may not be controlled, and then after implantation we try to do triamcinolone, so that if there is any vitreous tag we try to remove it, that will be visible with the triamcinolone, so that vitreous is also cut, so that there is regularity of the pupil and also no tag of the vitreous.
Yee Fong?
It's not fair to go last because all my points are taken. But, yeah, okay. If there's one other thing to add is to I do the vitrectomy through I do bimanual, so I do it through both the ports, so that I make sure that I don't neglect any clock hours, if you like, because the temptation is sometimes if you just do it through one part, one-handed, one side, you miss out certain parts that you don't do sufficient vitrectomy. Particularly important is to make sure the vitrectomy covers a large part of the postural capsule, post-postural capsule.
The subcapsular region, right?
Yeah,
That's
subcapsular area, yeah. Mm.
Okay, so I'm going to tell you what I tell my fellows. They hate me saying this. I go, no Harry Potter maneuvers. And what I mean about that is the magic wand, you know, training, you want to put the vitrector in the vitreous and they want to do the magic wand movement. And I say the modern machines will do the work for you. Just keep your hands still and steady. And then when you go under the capsule, it's nice, slow movements. Would anybody disagree with that?
Yeah, no, absolutely.
Okay. So let's go back now. This is controversial. It looks like all of us have a very similar technique, but there are many people in the world who like to put the lens in the bag, close the eye, and then go through pars plicata or pars plana, depending on the age of the child. I was trained that up until 4, it's pars plicata. After 4, it's pars plana. So whatever you've been taught. But there are many people who like to go in that way, do their capsulectomy, and then do a vitrectomy, and they get good results. So any comments, any experience in using that technique?
Ken, I do the pars plana more often than I do anterior if I'm going to place an intraocular lens. And the reason is I like to be able to place the intraocular lens in the bag while the posterior capsule is intact, because then I can really be sure that it's in the bag. And then I remove all the viscoelastic. I leave the irrigation in the anterior chamber, and then I make my my pars plana stab. So, and I go 2 millimeters back up to the first birthday, 2.5 millimeters back to age 4. Beyond 4, I go 3 millimeters back. I think people are afraid to try it, but once you try it, it's incredible the control you get. The vitreous, the experts like some of the pediatric retina doctors have told me, if you're going to cut vitreous, cut it where it lives. Don't drag it forward. Go through the pars plana, learn to do it, and we probably should at least have it as an option that you feel very comfortable with.
Yeah. So how do the other people? How do the other panelists feel?
I do almost majority of the children through the limbal incision, using the bimanual technique. And if I'm very confident, usually I do posterior rexis and implant the IOL, and then otherwise, in other cases, even by lifting the IOL, doing the posterior capsulotomy after implantation of IOL in the bag, in many of the situations which I am going to show today also. So otherwise, I do from the limbal side more often, particularly in the younger children, infant and toddlers.
Okay, Yee Fong?
Yeah, I do through the normal limbal incision, and not make any additional incision in the pars plana or pars plica. I just, in my experience, I don't feel the need to make additional incision in the eye, because whenever you make additional incision in the eye, there's an extra procedure, the extra incision whereby maybe risk of infection may be slightly increased. So I do through the normal incision that I have, but again I use bimanual method. So the incision for the the vitreous cutter as well as the infusion is very small. It's typically 23 gauge, and I find that that's what I do. Yeah.
Okay, Ramesh?
Yeah, before I answer my question, I think there are many questions.
Go ahead.
4 and 5 are coming.
Yep.
I think 2, 3, 4, 5. It will change every 30 seconds. So I want the audience to answer that question. So even if you have not answered 1, 2, 3, it will come back. So please answer. So I would go ahead with always anterior route, and I do PPC first and then implant the lens, PPC and enterovitrectomy, and then implant the lens and then close it. But as a beginner, for most of the fellows, I teach implant the lens in the bag and then just lift the IOL and do the vitrectomy. I never go pars plana. Again, I agree with Yee Fong saying that I feel it's unnecessary, another route or another incision for the patient.
So just to clarify for the audience, because we're getting questions, Ed, you're doing a vitrectorexis, right? On the posterior capsule.
From the pars plana, right?
Yeah, for the pars plana. Okay.
And
all right.
I can make a bigger posterior capsule opening with the lens already in the bag than I would dare make if I still had to implant the lens. And I don't drag vitreous forward. So when I started moving to the pars plana, the incidence of having a vitreous wick that I didn't see before and having to deal with it at the end it was eliminated because I've already removed the OVD. I don't go back into the anterior once I do the vitrectomy.
Okay. I mean, I think that obviously we're all pretty experienced. We've all sort of got a comfort level of what we do. I think these are things that people think about. I don't generally do the pars plica approach unless it's a very young child and it's a very small eye. Now because we got so much to cover, I do want to share one other thing. So I'm moving on slightly, and I'm going to share this slide again, but I'm going to move on from this slide, and I want people just to comment. So I just want to remind everybody that while we're talking about the surgery, it's always important to keep in mind this child was referred to me with a lot of glare, and this was the morphology of the cataract. And then here's another close-up view. And on the retroillumination, you can see these opacities. I'm going to go back for a minute and unshare. Actually, I'm just going to unshare that for a minute. So the reason why I wanted to show that picture is that when I asked the mother about a family history, she said there was nothing in the family. And then when I asked, this child is now 9. When I asked about the child's first year of life, turned out that this child was getting renal stones when she was 9 months old. That cataract is a cataract that you see in hyperoxaluria. Now, it's desperately rare, but what I wanted to share with the audience and with the panelists and ask you to give back my input, what are the features in a cataract that make you think there's something else going on here? And how often do you examine family members? Ed, you're on, so you're already looking at me. Do you want to take that up?
Yeah, I mean, I think I routinely look at the parents in bilateral cataracts. Now, unilateral cataracts, I don't worry so much about those metabolic causes. I'm not sure that I'm good at looking at the pattern of the cataract and picking out the metabolic condition. But I do like to look at parents initially undilated, just to take a quick look. But later on, it's a good idea to get a more thorough look at the parents. And we work closely with the clinical geneticist to try to help us out.
Okay, how about Ramesh?
Yeah, I always try to check parents as well as siblings. In India, it's not very common that both the parents come, all the children come for the checkup. At some point of the time, I try to examine the parents and also children. And I asked fellows and others, residents, to look at three things. One is family members. Second thing is the morphology of the cataract. And third thing is the face. These three things, as a pediatric ophthalmologist, you need to do. Don't leave it to somebody else, because sometimes Ed may have a very good genetic team with him. We may not have it. So we need to give that clue to the pediatrician and things like that. So these are the three things I will look at it.
Jagat Ramji?
Yeah, always in bilateral cataract, we examine parent. Rightly said earlier that both parents may not come, but we also ask their children, other sibling also we examine. And sometimes even parents will we see the phakic glasses because all time operated. So we themselves recognize that okay, I have to see you. And then they are happy that okay, additionally free of cost we are examining parents also. So
Okay.
by and large, almost all the time, particularly as Dr. M.E. Wilson said, for bilateral cataract always, and for other also sometime.
Okay. Yee Fong?
Yeah, I do the same. I think it's crucial to examine the parents and the siblings if they do come along. Even if they do not, I often ask the whichever parent to take turns. The other parent come along the next visit. I think it's very important to have a clear understanding as to who may be affected in the family. And very often you will find that aid in our diagnosis, that aid also in discovering other children. There are instances whereby the older child presents with the cataract, and then there's a younger child involved, and the parents doesn't know about it. And then when they bring him along, then you diagnose something. So I think that part of the assessment is actually very important as a pediatric ophthalmologist.
No, I agree with you. I would just say two things that I think that are worth remembering. The pictures that I showed you are not typical of that condition. It's just that they're little punctate changes that go all the way out through the lens, not just nuclear, and those little kind of like spider-like lines, they always tip me off that there's something metabolic going on. Just two pearls that I always think about. If you have a male child with bilateral cataracts and you dilate the mother, you have to dilate the mother. If you see little punctate lesions in the mother's lens, that until proven otherwise, that male child has Lowe's syndrome. And if you see a prominent Y suture in the mother, until proven otherwise, that male child has Nance-Horan syndrome. So those are two little things that can really help guide your management. So we'll come back to this because there's a lot of questions coming up, but it gives me great pleasure now to introduce Dr. Jagat Ram. I've learned so much from you, as I have from Ed. I'd love to hear your talk, Dr. Jagat Ram.
Yeah. First of all, I am thankful to Dr. Ramesh, Dr. Ken, Dr. Yee Fong Choong, and Dr. M.E. Wilson to meet you here and giving me this opportunity. I will be speaking on infantile cataract surgery. Infantile cataract is one of the most important causes of treatable childhood blindness. When we see the children in our outpatient department, these are the picture that they are in the first year of life. Majority of these children, they have bilateral cataract, and almost 10 to 15% of these children, they have unilateral cataract. And it is a very visually significant cataract in these young children. And each child, I like to dilate and take their photograph, and these are some of the photographs. Zonular type of cataract is very common, and it is not uncommon to see posterior lenticonus and a different type of unusual cataract such as starfish cataract, posterior lenticonus, or we detect so many conditions such as PHPV and others. And these are children with the bilateral rubella cataract, and these are the children with congenital cataract with microphthalmia and microcornea, and these are absolute contraindication for implantation of intraocular lenses. Timings of the surgery: any visually significant unilateral or bilateral cataracts, I like to operate at 4 to 6 weeks of age if it is safe from the anesthesia point of view. Primary IOL implantation, I like to do even in children less than 6 months if appropriately selected. IOL can be implanted in eyes with the axial length of more than 17 millimeter and corneal diameter of 10 millimeter or more. SRKT and Holiday 2 formula have been shown to be the best post-operative outcome in pediatric cataract surgery. We do intraoperative keratometry and axial length and do the calculation of the IOL power. These are some of the various studies from Dr. Vasavada, Coker, and Dr. Choong et al. Primary posterior capsulotomy with the anterior vitrectomy is done in children mostly less than 8 years of age, any mental retardation, or those having nystagmus. Posterior capsulotomy, usually I keep about 0.5 millimeter to 1 millimeter smaller than the anterior. Anterior capsulotomy is larger. And this is a child with pediatric infantile cataract, and you can see the $1 million smile here. During this corona period, only recently operated. I dilated the pupil, and this was the picture after dilatation of the pupil, and then made limbal side port incision, and then stained the anterior capsule with trypan blue. This is the main incision. Needle cystitome capsular axis initiated, and then completed with utrata forceps. Size of the axis approximately 5 millimeter, and hydrodissection, and then removal of the cortex from the capsular bag. And even it was not anticipated that this was posterior lenticonus. The posterior capsule was loose. I planned implantation of hydrophobic acrylic IOL in the bag, followed by lifting of the IOL optic and doing primary posterior capsulotomy with the vitrector. Size of the posterior capsulotomy was kept around 3.5 millimeter or so, and then triamcinolone was injected, and any vitreous tag was removed, and rexis was made more and more refined. Suture was placed at the main section, and this was the picture after surgery. And this is another child initially having bilateral cataract, left eye operated for cataract surgery. And this is the picture usually on any of the first post-operative day. Lot of children, about 12 to 15 children minimum. It may vary from 10 to 25 or so. And this child with mask is recently operated. This is because now we have to keep the social distancing. So there is a problem of operating so many children. And visual axis opacification is one of the most important post-operative concern in children who undergo cataract surgery at young age. Studies have shown that primary posterior capsulotomy with anterior vitrectomy and IOL implantation has led to favorable result in the long run. Our study from PGI has shown that management of posterior capsule rather than IOL design and material influences the incidence of visual axis opacification after cataract surgery in children. And these are the goals of pediatric surgery: adequate anterior and posterior capsulotomy and IOL implantation, and long-term visual rehabilitation and good visual outcome is the ultimate goal. These are children where we have more than 15 years follow-up now, and occlusion therapy is the mainstay to achieve visual outcome, especially in unilateral cataract.
Dr. Jagat Ram, can I ask you to go back? We don't normally do this, but those pictures are so beautiful. Can you go back 2 slides to show those the transillumination pictures that you just showed?
This
there,
one?
just there. What I would like everybody to comment upon, and this is very unusual. I know we don't normally interrupt speakers, but these are such beautiful pictures, and they really demonstrate something very powerful. I'm going to make my observation. I'd like everybody else to make those, and then we'll come to Ed's talk. What I notice here is if you look at the pictures on the right, I assume that what you're seeing is a lack of lens epithelial cells. And what I think Dr. Jagat Ram does, which I have been doing now for a number of years, is I think you spend a long time polishing the capsule. Is that correct?
Yeah. Actually, this slide which you are seeing on the right side, this is about, I think I have a follow-up of more than 20 years. That time this IOL was implanted, and this is a MA60 AC IOL, or this is implanted, and big rexis is there, and there is accumulation of lens epithelial cell inferiorly, and there are some other picture where it is much more than this these lens epithelial cell proliferation. On the other side, if you see the picture, it is a pharmacia IOL which was not now available. It was available about almost 15 to 18 years back, and this is a PMMA IOL on the other side, and it is a very nice anterior rexis, and IOL is placed in the capsular bag. I have follow-up of more than 10 years and more than 15 years this child.
This is amazing. So just very quickly across the panelists, do you all spend a considerable time taking away the lens epithelial cells from on the anterior capsule and the posterior capsule, no matter what you do to the posterior capsule?
Yes, I do actually. I think it's very important to do a proper polishing, and I approach it from bimanually. So I make sure that all quadrants of the capsule in all the areas I polish it. You can see the sort of like ground glass appearance if there's any lens material there. So I just polish them away. Yeah, I think that's very important in reducing the risk of opacity of the visual axis.
Ed?
I don't spend a lot of time on the under surface of the anterior capsule. I do some, but the literature is conflicted on whether that's important or not. So, you know, I think that maybe it's it's something that it may be important. I don't spend a whole lot of time going 360 and spending a lot of time on it.
Ramesh?
Yeah, Ken, I do always. Sometimes I spend the step which takes maximum time is that polishing. It really takes a lot of time, because one end to the other end, it really takes a lot of time. And I do undersurface the anterior capsule, as well as I try to reach up to the equator.
Yeah.
It's an observation. I don't have a publication, but if I don't do it in some of the cases, I see a clump of epithelial cells coming to what you can see in one of the pictures earlier it was shown. So I try to in all cases.
Yeah, I do too as well. So sorry, Dr. Jagat Ram, please continue. I didn't mean to interrupt, but it was such a beautiful picture. I wanted to raise that idea.
Regarding that question, I also spent some time, but as Dr. Emmy Wilson said, from my point of view, it is almost impossible to polish the total undersurface of the anterior capsule and remove all the lens epithelial cell. I think it is the capsulotomy size and precision of implantation of IOL which matters. And this is again, I think already said. And conclusion, congenital cataract is an important treatable cause of childhood blindness. It should be managed properly to achieve good visual acuity. In the bag placement along with primary posterior capsulotomy and anterior vitrectomy is essential in the younger age group, particularly because my topic is infantile, but I try to do even up to 8 years of age. Post-operative follow-up are inevitable to achieve optimal outcome, because only we know the complication if we follow these children up. So we always follow the children which I have operated are now 30 years, 32 years. So I have a lot of children more than 20 years. I think a lot of. Thank you very much.
Fantastic. Thank you so much. Ramesh?
Yeah, I think we'll go ahead with the talk of Dr. Wilson. He will be talking about toddler cataract, pediatric cataract surgery. Before he comes up, he can share his screen. We have displayed the next few questions, 6 and 7. I really appreciate if all of you can have a look at it and answer that. And you can even go back to the previous questions if you have not answered. After Ed's talk, I will show the results what we have been showing on the Menti survey. Dr. Wilson, you can share your screen and thank you.
There, thank you. I was asked to talk about cataract surgery in toddlers. I wanted to start by saying that, we're talking about intraocular lens implantation in kids, and this started probably commonly in the 1980s. It's been a long time. Here's an editorial, November 1996 in Ophthalmology, about it being the standard of care. Yet in the US, it's still not FDA approved. We're still struggling with it being off-label, and we're trying our best to work on that. If you haven't read this, I really think you should. This is an excellent article. We had a committee as part of ASCRS that did a white paper and went through some of the history and some of the literature trying to influence our United States FDA. But this was in 2007. You see a lot of prominent names there in our group, and I think that's something you ought to go back and read. This is just to show you the frequency for my practice. I sort of split this up into 3 groups. I think differently about the tiny infants in the first quarter of their first year of life, the first 3 months. And then I look at this toddler. I'm expanding the toddler age in yellow. I think of that as a second group. And then I treat the third group a bit differently as well. So we're going to concentrate more on that second yellow group now. Now, this is from the Pediatric Eye Disease Investigator Group. They have a registry. My database is not in this registry, but this was collected from a lot of practices across the United States. This is unilateral. You can see that 6 to 12 months, you're starting to see some intraocular lenses, and then from 1 to 4 years, the majority are implanted with lenses. In bilateral cataracts, same story. The very early patients, these practices were not implanting intraocular lenses very commonly, but as you get to 1 to 4, again, very, very common. Now, this is really interesting. We formed a group and studied patients. We call it the toddler aphakia and pseudophakia study. This was patients that the IATS, the Infant Aphakia Treatment Study surgeons, these were older kids that we operated during the same years that we were recruiting tiny infants for the IATS. And what we found in unilateral, and now we're publishing the bilaterals as well, a dramatic drop in the reoperations, the visual axis opacification, all the complications that were found in IATS seem to drop off drastically after 7 months. And 94% of this group were implanted with implants. So despite implanting, something changes after 7 months. And between 7 and 12 months and 12 and 24 months, it was the same. So something changes after 7 months that makes the implant much more successful. Now, I do surgery a lot of different ways. I'm perfectly comfortable doing things from an anterior approach, but my standard in this toddler group is bimanual removal of the lens, placement of the implant, removal of the OVD, and then I can fashion my posterior capsule through the pars plana. I don't tend to use a trocar. I was taught by Steve Charles that you don't need a trocar if it's one time in, one time out. Trocars are for tool transfer. We tend not to do tool transfer, so I do one incision, 25 gauge vitrector. And in these toddlers, I really still feel that the vitrectomy is needed. You do get a lot of cortex that is remade, but it tends to stop at the edge of the posterior capsulorhexis. One thing is that if you choose to leave the posterior capsule intact in young children, just be aware that if you don't reach for the ag laser soon, some of these become very hard to treat, and we end up, if we wait too long, having to go back to the operating room, doing that second half of the procedure I showed you, doing a very quick pars plana removal. Sometimes that's necessary if the PCO goes too far. I wanted to show this short video from Marie-José Tazignan. It's an elegant way to handle implantation in the toddler group. This is a bag in the lens. I don't have access to this in the United States, although I really would like to, and hoping that at some point we can. But those of you who have access to the lens, it's a very elegant way of doing it. Now, I wanted to touch base on this because I know most of you, when you implant a lens, you probably use some age-related chart like this. This is a chart that we have for if you want no myopia at age 20. Sometimes you're willing to accept some myopia at age 20, but not all 3-year-olds are alike. And I want to draw your attention to this article in the American Journal of Ophthalmology in October 2019. We based this formula on bilateral cataracts age 2 and above. The infants are going to be really, really hard to predict, but age 2 and above, you can use this formula. And here's the way it looks. So if you have a 3-year-old, maybe you leave +3. If this first 3-year-old has an axial length of 21.95, then based on the formula I just showed you, I can predict that the axial length of this child at age 20 is going to be 24.19. And then I put that into the IOL formula, and the IOL for plano at age 20 would be a plus 18. A plus 18 in this child would mean that I would leave that child plus 4.86 after surgery instead of plus 3. Had I used the 21 that you might have planned for, then it would have been minus 2.14 at age 20. Now, here's another 3-year-old. These are real cases. The axial length is 20.34. My formula predicts 22.73. I was going to put in a 30 and leave the child plus 3, but instead the formula tells me that a 25 would give emmetropia at age 20. And so I need to really leave this child plus 6.27 if I want plano at age 20. If I do the lens I was planning to use, I'm going to end up with minus 3.66 at age 20, and that's still not terribly bad. So this formula, and you can read the article to see how we came up with it, is the first step in trying to customize what your implant is going to be. And using the formula, you can say, I'm happy with minus 1 at age 20, I'm happy with minus 2 at age 20, and figure it out that way. So I want you to look at that article and read it carefully. Now, I'm going to finish with just a couple of quick videos because I wanted to show first this overlay. The Zeiss microscope we have has a Rexus overlay, and I can adjust the size of these circles. I just thought that was something that I really like. As I'm doing a Rexus, I can use that overlay to help size it. And I also wanted to show, because it was mentioned, this Clody radiofrequency diathermy, especially in trauma cases or cases with calcific capsules where you might not be able to do a manual tear very easily. This device is beautiful. It's not as stable an edge as a manual Rexus, but it's a pretty good edge. And it's diathermy. You paint a circle. There's the capsulotomy. So I just wanted to show that briefly. And this case with a very 4-month-old, very calcific capsule, I chose to do a wrinkle of optic capture. This is bicapsular capture. I'm putting this lens in, and I want to show you that when the capsule is somewhat calcific, it can be really hard to capture the optic. But this is a technique that's sometimes used. I find it's easier to exchange the implant later if I don't put it in the bag, if I actually do a bicapsular capture, 3-piece lens. The haptics are in the sulcus, and this also prevents the visual axis opacification. So that's it.
Thank you so much. Thank you for that. Yeah, we just have some questions, mainly questions related to these talks. Your preferred technique in toddlers, preferred technique in infants, and what have you learned from this webinar? So this 7, 8, 9 questions will come up in the next few seconds. I really want to thank Ed for an excellent talk. Maybe Ken can start some discussion with some questions which are.
There are so many questions flying around, and I think what we should do is, so let's start off with the IOL power. So I think for me, the most important thing is to try and understand emmetropization. I think everybody, especially the trainees out there listening to this, you need to understand the normal growth of the eye. And when you're born, the axial length is about 16.5 millimeters. There's a rapid growth in the first 18 months of life. So it makes perfect sense to make the child more hyperopic. And we'll come to everybody's choices. But one of the things I want you all to think about is think about the bilateral child. I mean, I think, you know, Ed, you said very nicely that the IATS patient population was different to this over 7-month-old, but they're also unilateral. I think there's a huge difference between the bilateral, usually crystalline gene mutation child to a child who's unilateral, likely PHPV or posterior lenticonus. It's a different animal. So it's not just the age, but the cause of the cataract. But that aside, how would you deal? You're in a country where you're not going to be able to get visual rehabilitation quickly or easily for the majority of your patients. What would you do in terms of leaving a bilateral child post-operatively? Would you leave them hyperopic, and if so, how much? So let's kick off with Ramesh. I'm going to ask you that question first, and then we'll go to the rest of the panel.
Yeah, I'm in a country where many patients are bilateral, and we do have unilateral as well. Wherever possible, I don't look at the age, I look at the eye, and I look at the patient. I treat accordingly. I don't look at the age, because the child can be 6 months or 7 months, still the eye can be very small, as Dr. Jagat Ram showed, a microcornea. In spite of being in a patient where they cannot afford glasses, I would still not put an implant there. So I would look at the patient profile and then decide based on that. Most often in bilateral cases, I tend to implant lens, provided Dr. Jagat Ram showed the selection criteria. What is the eye profile? What is the patient profile? And also the socioeconomic status, and also a person's surgical experience. I would tend to do implantation.
What's your post-operative aim, though? What are you aiming for? So let's say it's a 6-month-old.
Yeah.
What do you aim for?
Bilateral cataract, I would still undercorrect 30%, unless in 2 situations where there is a progressive myopia in parents, and also the child has cortical visual impairment, because we do get a lot of children with that. So I tend to go to the emmetropia. Otherwise, as you know, the axial length really progresses very fast in the first 12 or 18 months. I would still undercorrect around 30%, maybe close to around 8 to 9 diopters of undercorrection.
Okay. Dr. Jagat Ram?
If a child is 6 months of age, almost 25 to 30% under correction to compensate the myopia. If in bilateral cataract, but if it is unilateral, I try to keep much more under correction, so that residual refraction is more toward the emmetropia. Or to compensate the myopia. So it should not be myopic shift, but they are still hypermetropic. So under correction is the rule, as Dr. Ramesh said.
Okay, Yee Fong?
Well, in this part of the world, we are not so concerned about moderate myopia because that is the norm. So for 6 months or so, I will aim for hyperopic correction of +3 to +4. Up to 1 year old, about +3, +2, +3. Above 1 year old will be about +2, 2 to 4, +1, and thereafter I'll aim for emmetropia. My thoughts about this is because I want the child to see fairly clearly, and sometimes we have difficulty getting the optical correction in these children. And I want them to not be disadvantaged by a high degree of emmetropia. And therefore, I worry about the myopia later. We can sort it out later in life, but importantly, we want to give them the best shot when they're still young.
So Ed, a lot of people. I agree with you. A lot of people are saying, with the numbers that you're suggesting, according to your equation, you're going to give quite an amblyogenic insult to the child. As it's a bilateral case. How would you discuss that? What would your answer be?
I think you individualize. So the chart I showed with ages is what you would aim for if you did not want any myopia at age 20. Now, when you individualize, if I have a unilateral cataract and I'm already late getting to that child, I know that it's going to be a battle to get glasses. It's going to be a battle to do the patching. I'll aim much closer to emmetropia, try to give that child a chance. I know I'm going to do an IOL exchange later. On the other hand, if I have a set of parents who wear glasses, I know that they can get glasses of any power early. It's bilateral. They are concerned about reducing the risk of an IOL exchange later on. They want this to be a lifelong implant with good vision even as a teenager. Then I'm going to aim for the full amount of hyperopia. So you really have to individualize. It's okay. I just want people to know that they're going to get high myopia and they're going to be doing an IOL exchange if they get close to emmetropia. And I don't want kids at 10, 11, 12 with broken glasses who are -8, -9 functioning out there, not getting any follow-up.
Yeah, I think those are all good points. So for me, the myopia, if it comes, I do undercorrect. I think I'm sort of halfway between what you're doing and what the others are doing in terms of the amount of undercorrection. I'm quite happy to put an ICL in a 16-year-old's or a 14-year-old's eye on top of the original implant rather than do an exchange, because our refractive colleagues, are putting ICLs in crystalline lenses. So I think that's something that you can do. Let's just talk about the type of IOL. The videos I saw, it looks like yourself and Jagat Ram, and I think Yee Fong as well, are using one-piece injectable foldables. Is that right? As your standard?
Yes.
Ramesh?
Yes.
Injectable foldable is the standard what I use in most of the children in the bag implantation. But yeah, go ahead.
Go ahead.
If I'm putting in the bag, I will open a single piece lens. If I'm not sure, I will open a 3-piece lens because I can convert into a sulcus fixated or optic capture or either ways. That's my.
So you're making a very important point, right? Do we all agree? I'm not going to assume. Do we all agree that if you're going to do optic capture, that you use a 3-piece lens? That a 1-piece lens is probably likely to dislodge as the capsule phimosis. Yeah. Do we all agree on that?
Yes.
Okay, so 3-piece lens. If you're going to put a lens in the sulcus, do we all put in a 3-piece lens, or does anyone put in a 1-piece lens? I'm talking about foldables. I'm not talking about PMMA.
There's one single-piece lens that performs very well in the sulcus, and that's the Rayner lens. It's a Rayner C-Flex lens. The 3-piece is best for the sulcus because it has a posterior angulation. It's made for the sulcus. But I don't like the haptic design. It really decenters a lot, and I'm not a fan of the 3-piece design all the time. So I've found over the years, and this has been published by others as well, that the Rayner lens, the single-piece Rayner lens does well in the sulcus, even though our other standard single-piece lenses do not.
Okay. What about others? Any other comments?
Yeah, if for I think a capsular bag, I always use a single piece IOL by and large, but never put these. I do not put any of these single hydrophobic acrylic IOL into sulcus. That is what I do. Although I don't have Rayner lens available, but when I have to put any of the IOL into sulcus, it is always 3-piece IOL. Whether I put into sulcus or I capture it, that will depend upon the situation.
Okay.
And the Rayner is a hydrophilic acrylic. Just
Sorry. That's hydrophilic acrylic.
Yes. Yes.
Ramesh.
Hydrophobic. You're talking about the lens.
Yeah. Lens type and design. Yeah.
Hydrophobic, single piece most of the time. Acrylic, 3-piece sometimes. These are the two lenses I use.
Yee Fong?
Yeah, I use if I can implant in the bag, I'll use a single piece foldable acrylic hydrophobic. There's also a question about whether you want to use the one with the yellow tint or not yellow tint. I started off using the tinted lens by Alcon, but I find that there's a lot of glistening or opacification in years to come, typically above 8 to 10 years. So now I've moved towards a clear lens by another company, but also hydrophobic single piece acrylic foldable. But if it's in the sulcus with lens capture, then I will have to. I normally use a 3-piece lens.
Okay, so I'm going to be slightly controversial. I'm going to say that I use a 3-piece MA60 AC lens. I have no financial interest in the lens, but I've always used it, and that there's a technique, a learning curve about folding that lens and putting it in a small, in a child's eye. And the reason why I do that, and I make my fellows do that, is that I have this belief, it's the Karate Kid belief, wax on, wax off. That if you do what you need to do in the difficult cases all the time, that when you have that extra stress of where the bag is not stable, you're going to have to put it in the sulcus, and you're not sure if there's some vitreous, and that anxiety builds up. I don't want people to worry about having to remember how to fold a lens and put it in the eye. So I always use the 3-piece, and I use it so that if I'm in the eye and something's not stable, I can put it in the sulcus. So that's my approach. So do any of you inject a 3-piece, or do you have to fold it and place it?
No, I inject a 3-piece. Yeah.
You can inject a 3. That's fantastic.
Oh yeah, absolutely, absolutely.
Yeah, I also inject 3-piece IOL.
Perfect.
Yeah.
All right. Well, I
You
clearly
can inject 3-piece to 2.7, 2.6, 2.7 incision.
Okay, so I've never injected a 3-piece. I've only ever injected 1-pieces. So I must learn that technique. So I fold. Ramesh, do you inject a 3-piece?
Yeah, I inject 3-piece. Most of the times I put the haptic in the sulcus and then I slip it down, because sometimes if the posterior capsule is open, it can really go in a wrong direction. Having said that, sometimes I don't use injector as well. So most of the times I inject.
Okay, so there are so many excellent questions coming through. So the question is we've all described different techniques of how we do the rhexis, etc. Anybody use the vitrector rhexis on the anterior capsule? It's a normal capsule, hasn't got a plaque. There's no pyramidal cataract on it. Anybody use the anterior vitrector rhexis?
I use the vitrector rhexis if I'm not placing an IOL.
Okay, yeah.
So in an infant, it's one time in, one time out. So you can cut the capsule, take the lens, cut the capsule. But if I'm going to put an implant in, I like the stability I get from a regular capsulorhexis.
Anybody else? Everybody agree with that?
Yeah.
Yep.
Okay. All right. So next question is, do you always try to make the opening of the anterior capsule smaller than your optic? So if the optic's 6 millimeters, in other words, is your anterior opening going to be 5, 5.5, 4.5? Does everybody do that?
Yeah, actually, yeah. I try to keep the anterior capsulotomy approximately 5 millimeter or up to 5.5 millimeter. It may vary from 4.5 to maybe 5.5 millimeter, but not larger than that. My aim is to make approximately 5 millimeter. So I never try to keep it 6 or more larger. So I keep it between 4.5 to 5.5 millimeters.
Okay, if nobody has anything else to sort of say differently, let's move on. Again, people are asking, do you think that staining a capsule with trypan blue changes its characteristics and makes the capsulorhexis easier because it becomes less elastic?
Yeah, I feel that while staining the anterior capsule with trypan blue dye, there are two things which happen. One is visibility definitely improves, and I think rigidity or on the elasticity also it make difference. Although I have not carried out any study, but this is my observation. It will make some difference on the elasticity also. So you succeed in completing the Rexis with trypan blue dye, particularly for beginners.
Do you use any other dyes? Do you use anything else, or do you always use trypan blue?
No other dye, only trypan blue dye.
Okay, Yee Fong?
Well, I only stain the capsule in cataracts that do not have good ray reflex. So it's hard to know. Anecdotally, it feels not so elastic, but it could be because in the denser cataract, maybe the capsular morphology changes as well. I'm not sure. But the impression is that it's less elastic, but I don't routinely stain all my patients. I only do that those that do not have a good ray reflex.
Ed, I think you did some work on this, didn't you?
Yes,
I seem to remember
well,
a paper that you wrote.
We didn't compare in the lab trypan blue versus no trypan blue. We just studied the anterior capsule in other ways. I can't tell in the OR. I can't tell a difference. And I've put trypan blue, and then the next case no trypan blue. I can't tell the difference. I know that there are some experiments that seem to show that it changes the capsule. If it does, it's imperceptible to me.
Okay, Ramesh?
I like it for visualization, but I'm not sure it changes the character of the capsule.
Yeah.
I don't use the trypan blue, Ken, in most of the cases, unless it's a white cataract or the visibility is very poor. But I insist always my fellows to do capsular Rexis under trypan blue. I feel it makes a difference. I don't have a publication or anything, but it makes a difference because somehow when you use it loses its elasticity, and that's what even the fellows feel very comfortable doing this under trypan blue.
Yeah, I would agree with you. Again, we got so many questions coming in. I think this is a superb question. The question is we all have different techniques. Does the technique that you use for the posterior opening, whether it's pars plicata, pars plana, or anterior, change what you do post-operatively? So Ed, looks like you do a lot of pars plicata, pars plana. Is that any different to when you might do an anterior approach on its own?
Well, no. I mean, I'm comfortable doing either one, but I don't treat them any different afterward.
Okay. Anybody else? Ramesh, Jagat Ram, Yee Fong?
Yeah.
I don't do pars plana, so can't comment on that.
Okay.
Yeah, sorry.
That's all right.
Yeah.
Ramesh, Jagat Ram?
I can comment on two techniques, Ken. One is we don't do pars plana or placata at all, but we do technique like do PPC and AV and then implant the lens, and do implant the lens in the bag and then do PPC and AV. Fellows at the beginning stage, they try to learn that, because unless they do this for few cases, you can't have a good feel on everything. So
Right.
when I look at this post-operatively, I look at it as a safety rather than it makes any difference. It's
Okay.
elegant, it's easy, it's more controllable if you do a PPC first and do it. But ultimately, in the long run, it makes that surgery safe in that beginner. Otherwise, I don't see any difference between these two techniques. I can't comment on the pars placata.
Jagat Ram?
Yeah, actually, I do through the limbal incision, and then primary posterior capsulotomy, anterior vitrectomy, and then implantation of the IOL. That is by almost 90% cases I do like that. Pars plana only capsulotomy I do when it is a secondary capsulotomy, when there is a much more fibrosis and it is not approachable through the limbal incision. And older child, I think there is no pars plana I use for very thick capsulotomy, and particularly when I need to, when you cannot insert the even vitractor beyond the beyond this optic of the IOL. Mostly I do secondary capsulotomy later on through the pars plana.
Okay, so look, there are lots of questions. For those listening out there watching right now, we will answer your questions. We have about 5 minutes left. So there are some there's one question I want to ask. We've got a global audience. It looks like we have viewing figures from approximately 78 countries. When you go abroad and you do surgery, and I'm sure you've all been invited, right? How do you adapt your technique so that you don't run into problems depending on what's available locally? I think this is a really important question because we all go and do volunteer work, but my worry always is, am I going to do something because I'm so used to doing it with my technique, with my facilities, with my equipment? So Jagat Ramji, let's start with you. I know you do so many volunteer camps. What are your tips to people who might want to go and do this around the world?
Actually, the technique which I use here in the institute, I use there also. Particularly there, I may use more often the trypan blue dye for continuous curvilinear capsular axis, and I will also tell to keep a single plus also the 3-piece IOL ready. So that I may not fail to implant the IOL, but by and large I am successful even implanting the single piece IOL.
Perfect. We haven't got much time, so we're going to move on. No, I apologize. Ed?
Yeah, I would definitely change in some of the places I've been. The quality of the microscope is important. I need a good red reflex view to do the technique pars plana. If I don't have that, then I'm going to switch to the simplest techniques, everything anterior. I think you really have to match the technique to the equipment that you have and stay safe.
Okay, Yee Fong?
Well, I'm a minimalist, so I tend to simple instruments like the Capsulax forceps. I use a Simcoe rather than expensive phaco machine to remove the lens. The only thing is a vitrectomy, so I think that will be maybe limited in certain places. But I'm happy to, if you just give me a 20-euro vitrectomy, you can still approach the surgery.
Okay.
And importantly, I think suturing the wound is important as well.
Totally. Ramesh, I'm not going to ask you because we're running out of time. You need to talk about the Menti and sign off, and then I'll say the last words.
Thank you, Ken. We just had some responses for the Menti questions. The first question was, where are you from? We can see almost 70% are from Asia. What are you? The 80% are pediatric ophthalmologists. We have 21% are adult ophthalmologists who do pediatric cataract surgery, and we do have few orthoptists and others. The next one was, what is the geographical location? We have majority from Asia, but about Europe, North America, South America, Middle East, and Africa, they're kind of almost similar. 54% from Asia, rest of the percentages are from equal from all the other locations.
Fantastic.
And then my choice in infants with bilateral cataract, when all the things are okay for IOL implantation, the 60%, 40% are for glasses and aphakia, 10% are for aphakia and contact lens, and rest of the 45% are for intraocular lens. When it comes to toddlers, the intraocular lens percentage has improved up till 75%. It's still not 100%. The surgical technique, most people prefer primary post capsulotomy, anterior vitrectomy, and in the back. 10% prefer optic capture, and some others for other technique. My preferred technique for anterior capsular axis is manual for 80%, 6% are for vitrorexis, 8% are for push-pull technique. Now, post-webinar, the percentage who are changing in terms of for intraocular lens has risen to 55% for intraocular lens, and rest of them are not for it, and 10% are not sure for that. And last question is my preferred technique for anticapsular access. It remains the same. And final question, would you consider IOL in infants? 48% said yes, 11% are still not sure, 25% no. And the last thing, what is the best thing about this webinar? It's an open-ended question. The most important thing I can see here is on the largest number is discussion, videos, speakers, and information. There are almost 100 items. These are the largest one what you see. I just want to finish up by thanking the group. I would just take few minutes, Ken, just 1 minute.
So while Ramesh is doing that, we want to thank NTOD. Thank you so much for this platform. You've been superb as always. We want to thank Akila and Dara, who are behind the scenes doing all these things for us, setting everything up. We want to thank you. Ramesh, go ahead.
Yeah, I just wanted to show this slide of upcoming webinars. We still have around 9 webinars coming. The next week we have 2 more webinars. So please join all the webinars. And I really want to thank all of you who are watching around the world. A big thank you to all of you. A real big thank to all the panelists today. We had a fantastic discussion. It was a free-flowing discussion. We would answer all the rest of the questions and get back to you. We really missed Darius, and we wish his wife a very good health. I really wanted to, as Ken said, NTOD team, they are working week after week for this, making this webinar very successful, and also our admin team from WSPOS. Thank you. Over to you, Ken.
Okay, so my last thing I wanted to say, please join the YouTube channel, which is the WSPOS channel. Anything that comes up, we'll contact you directly. Please do the survey. Remember, together, apart, all over our world, WSPOS. Membership is free. Join the international listserv, Write to David Granite, WSPOS Facebook page. Everything's there. It's your society. Namaste, salam alaikum, thank you, goodbye. All the panel, this has been the most fascinating discussion I've had for a long time. Yee Fong, thank you. Ed, thank you so much. Ramesh, Jagat Ram ji, goodbye. God bless everybody. Have a wonderful day.
Thank you.
Thank you.